posterior, as you know. Then of course the prominence here over the femur is the medial epicondyle, and this is where the medial collateral ligament is most commonly injured. Yeah. So in patients who have, ski injuries, the two most common injuries are either medial collateral ligament or the anterior cruciate ligament. And so if you press just here on the medial epicondyle, they'll jump up and say, oh, that's where I'm getting my pain. So then of course they have a MCL, medial collateral ligament injury, and then you can palpate down, straight down, and actually you can feel it, almost like a tight band running down here, yeah, down to the tibia. The other point that people can get is pain at the pes anserinus. So the pes anserinus is where the hamstrings, so you have the medial hamstrings coming around and they attach right here, usually about 3 finger breadths below the joint line and just a little bit anterior to the insertion of the medial collateral ligament. So sort of you have the insertion of the medial collateral ligament, the tibal tuberosity, and this is the pes anserinus, and that's where you can get bursitis. They talk about if you have tight hamstrings, pes anserinus bursitis as well. Yeah. Okay, so that's the general palpation, as you can see. So even from that, you can pretty much get a lot of understanding of what's going on. Next, in terms of the collateral, again, varus valgus in full extension. So this is valgus, varus, okay, and generally I prefer to bring the knee off the bed. The reason why is if they're a big person and maybe you're not as big as them, it's you don't have to hold the leg. Then you just bend the knee to 30 degrees and then they're relaxed, and again, valgus stress, varus stress, yeah? And then you can again check it on the other side to see what the symmetry is. So it's always at 0 and 30. The MCL is relaxed at 30 degrees, and that's because the two ligaments that provide stability in terms of valgus and varus. Varus would be the MCL as well as the ACL. Yeah, so the ACL is a secondary restraint. So if they're like a grade 3, then they probably have an injury to the anterior cruciate ligament as well. Okay, so that's for the collateral ligaments. Now for the anterior cruciate ligament and the posterior cruciate ligament. People do it very differently. Let me just show you on the other side here, because then it's easier to see. So the Lachman test, which is the most common, actually all you need to do is you just flex the knee up to about 30 degrees and the patient is relaxed. And even if they're in pain, they just had the injury a week ago, they can just relax like this. And then I would just, using my left hand, I would just push up and then down, push up and down like that. Yeah, so James has a stable ACL. So it's just very slight flexion till they're relaxed, and I just push up and down. Some people will, yes, they'll put their knee underneath and they'll do this, which I find a little bit more cumbersome, because actually all you need is about this much flexion, and then the patient is actually more relaxed like this, that I find anyway. So they're the two ways to be able to do the Lachman. In terms of the anterior draw, then you want both feet up and equal, and you sit on their feet. You just tell them, you make sure the hamstrings are relaxed. So that's important, otherwise you can get a false negative. So you just press up and make sure the hamstrings are relaxed. If they're not, just ask them to relax. You put your thumbs at the front, and again you pull forward and backwards, forward, backwards. Same, relax, forward, backwards. And you look mainly on the inside, is there a movement and how much translation you get, and is there a soft ending. In terms of the posterior sag, like I was saying, what you look for is, if you follow, here's the femoral condyle here, the medial femoral condyle, it goes into the sulcus here, the soft spot, and then for the tibia, the tibial plateau will actually come back forward again. So you'll feel like a hill, a valley, and then another hill there. Yeah, and that's what you should feel. Now, if you feel a hill where the medial femoral condyle is, it goes into the valley, and it just stays in a valley, then that means that you have a posterior tibial sag, you have a PCL injury. And actually I've picked that up quite often. People don't even know it. And they say, oh yeah, I've had some, chronic sequelae for PCL or grade 1, grade 2 PCL injuries is actually patellofemoral pain. Because what happens is the tibia sags backwards, it increases the pressure on the patella, and over time you get patellofemoral arthritis, chondromalacia patella. And then when I feel, they say, oh, you know, you have a grade 1, grade 2 PCL, and they say, oh, you're the first one to pick that up. So you should always check it. And then if it does sag, then once you pull it up, you'll see that the second heel is reconstituted there. So that's for the PCL. And then the last one is the pivot shift. The easiest is to essentially ask them to relax as much as possible. You lift up the leg from the ankle, and then they go into a slight hyperextension, and as you flex, you'll feel like a clump, yeah, as it subluxes forward, clump like this, yeah. And of course, to have a positive pivot shift, you need an intact medial collateral ligament, yeah. But it's a little bit more difficult in the clinical setting. Patients are usually a little bit apprehensive, and they have to have a lot of rotatory instability. But of course, if they do have a positive pivot shift, then it really means that they are very unstable, and they will be symptomatic for sure. Yeah, because that gives more of a rotatory assessment on the knee. Then in terms of the meniscus, okay, so the classic test is the McMurray's, where you'll place the fingers on the joint line, you'll flex the knee up to 90 degrees, you will externally rotate and then extend the knee. That's for the medial meniscus, just like this. And what you're getting is essentially